a bit of history about sleep because it's not conventional in terms of medicine, it's not cardiology, it's not pulmonology. It's a little different. So I want to give you some history about how the whole concept of sleep medicine, clinical sleep medicine began. It began in the basement at the University of Chicago, the sub-basement at the University of Chicago by a group of psychiatrists. And these psychiatrists were interested in dreams. And they began to notice when they would watch people sleep that there were little flicks under the eyelids where they could see the conjugate eye movements. Many of you that have animals have noticed that your animals from time to time during sleep will have these little periods where they have little flicks. And the psychiatrists learned that if they woke the patient during these episodes of rapid eye movement, they would almost invariably be recalling a dream. And they realized after a while that they have to go in and look at somebody and see if their eyes were moving to see if they were in what later became called REM sleep. They needed to do it electrophysiologically. So they began to hook up electrodes, the outer cant of the eyes. And when they could see these conjugate eye movements out on their recorder, they knew the patient or subject was dreaming, and they actually went in, woke the patient, and got the patient to report their dreams. So that began this whole area of studying sleep and trying to understand some of the dynamics of sleep. It was thought for years that sleep was analogous to somebody driving their car in the garage and turning the engine off. The car sits there all night. Next morning, go back up, start the car again. So sleep was not really considered anything other than a quiescent time where you just parked your car and, nothing happened. But they began to realize when they began to study sleep electrophysiologically that it was a very dynamic period of our existence. And as you all know, we spend probably a third of our lives asleep. So they begin to study sleep electrophysiologically. They begin to define rapid eye movement sleep. They learned early on that narcolepsy was a condition that was associated with early onset rapid eye movement sleep. Normally, when we fall asleep, we have about 90 minutes before we get to our first rapid eye movement cycle. In a narcoleptic, they found out that they would go to sleep and go to sleep quickly, and within 3 to 5 minutes would be in rapid eye movement sleep. It explains a lot of the observations with narcolepsy. The field progressed. The ones that discovered REM sleep began to study breathing during sleep. They attached electrodes to the chest to measure motion. They put EEG leads on the brain to measure sleep by brain waves. They begin to characterize sleep in the various stages. For instance, stage 1 sleep is this light period where we will sort of, eyes get drowsy and you begin to drift. And when you're in sleep, the EEG pattern changes. And it goes from a irregular, rapid to a more regular alpha rhythm activity. And when you're actually in sleep, physiologically, you've had 2 epochs of stage 2 sleep. Now there's a big debate, and still is, about what is the onset of sleep. Is it the behavioral loss of consciousness, which is hard to measure, or is it the actual EEG recording of when you're in that stage of sleep, generally stage 2 sleep for 2 epochs, which is about 30 seconds of a recording on a polysomnogram. So most people now recognize sleep not necessarily as the actual behavioral drifting off, but it's more of the electrophysiologic when you're in a deeper stage 2 sleep. Stage 1 sleep lasts for about 3 to 5 minutes, and then you go into a stage 2 sleep, which is truly sleep, and you stay in that stage for probably overall combined through the night about 60 to 70% of the time. Out of stage 2 sleep, we'll typically move into what's called delta sleep or stage 3-4 sleep. That writes on the EEG a very deep sine wave type effect that's clearly obvious on the EEG. And this is the deepest sleep we all have. REM sleep is not a deep sleep. Delta sleep is the deepest sleep. This is the sleep that an 8, 9, 10-year-old pre-adolescent gets a great deal of. Probably 40, 50% of a pre-adolescent sleep is in delta sleep. This is the phase of sleep that if you, say, went to wake your child, you would have trouble waking them up. They wouldn't come around. They would be hard to wake up. This is the phase of sleep where night terrors are reported. Some of you may have had children or yourselves actually have been told you wake up screaming, perspiring, but you're actually not awake during these night terrors. It's in delta sleep. It's very deep sleep. It's the phase of sleep that is really the most restful. And after puberty, that percentage of delta sleep begins to drift away. And by the time you're in your 60s and 70s, you may only have 3 to 5% delta sleep. That's why we say that as we age, we don't sleep as well. We have more arousals and awakenings. We have less delta sleep. And so as a 60, 70-year-old, sleep is fragmented, minimal delta sleep. You don't sleep quite as deep, and you don't get as refreshing a sleep. Now, REM sleep, on the other hand, is very, very fascinating. That's considered sort of the third stage. We consider wakefulness, we consider non-REM sleep, and we consider REM sleep, because during REM sleep, the brain is particularly active. That's when we typically dream. That's when the body develops what we refer to as being poikilothermic. That means the body assumes whatever the environmental temperature is. I'm sure you've all awakened in the early morning hours with a little bit of perspiration up here. And that's your body trying to regulate your body heat by perspiring. Because REM sleep, you assume whatever the environmental temperature is. And the body will try to adjust for that with perspiration. REM sleep, we dream. If you wake somebody from REM, they'll almost invariably be able to recall a dream. They can't remember it after about 5 to 10 minutes unless you repeat that dream in your conscious mind as soon as you wake up. And that's what the early researchers used to do. They would wake people up when they saw the REM, or they saw it on the electro recording, and they would have them write their dream out. They would have them dictate and write it out, and they could understand their dreams a lot better that way. But the subject, the patient, would generally forget the dream after a few minutes or even during the day. They may recall they dreamed, but they don't know what the content was. REM sleep, as far as the breathing is concerned, is very erratic. It's where the heart rate varies a great deal. And it's believed, not actually proved, that when people who have sleep apnea get into REM sleep and they have long periods of irregular breathing, that's when the most likely time for them to have secondary effects such as a heart attack. Heart attacks, when they look at the time of day or night when they occur, is usually about 5 a.m. plus or minus an hour. That's when the spike in heart attacks are recorded for people that die. So typically it's during REM sleep that we're most vulnerable as far as breathing is concerned, as far as cardiac rate and rhythm are concerned, and that's believed to be when the oxygen saturation tends to drop the lowest, and consequently if you've got any type of coronary disease and your heart's irregular, that's when you're going to have those problems associated with irregularities, arrhythmias, or actually an MI. My history in sleep began in 1973. I was a fellow in pulmonary disease in Boston, and I decided I wanted to audit a course from a physiologist, a world famous physiologist at Harvard Medical School. And there were 5 of us, 4 Harvard Medical students and myself, and we met in his office. This guy was about 6'8", in his late 60s, had been the president of the American Physiological Society, and he had done some incredible work, particularly with conduction of ions across membranes, particularly as it relates to the lungs. So he was teaching a class on control of breathing, and I wanted to go to it. And after the second lecture, we were meeting in his office, and he looked down his long Anglican nose at us and said, "I'm not really interested in what I'm teaching. I'm interested in the sleeping brain. And if you guys want to stick around," he said, "I'll give you partial credit for this time you've been here, but if you want to stick around, I'll teach you what I'm studying as far as the sleeping brain is concerned." So we all stayed. We were fascinated, myself included. And he had done some experiments where he had deprived a colony of monkeys of sleep for days and nights, and had taken some of the spinal fluid from those sleep-deprived monkeys and injected it into monkeys that had been allowed to sleep normally. And within 15 minutes, those monkeys that got the injection of the spinal fluid from the sleep-deprived monkeys drifted into a deep sleep for about an hour and a half. And he was fascinated by that and felt that he had begun to identify a sleep-promoting substance. And as it turned out, he perfected that. It was referred to as a sleep-promoting substance S. It was a small peptide. I kept thinking years later that one of the pharmaceutical companies would get a hold of this and start making a drug that had this in it so that it can induce sleep. It never came about, but he published extensively on this. But he taught us about the sleeping brain. Well, I was fascinated with it. I went back to my chief, who was on the board of the New England Journal of Medicine at the time, and I kept talking about all this sleep stuff that I was learning about. So he walked in about a couple of months later to my office and handed me a manuscript. And it was from Stanford, and it was 26 cases of sleep apnea. Well, nobody had heard of sleep apnea. I went to the literature. There were a couple of references in the French literature about sleep apnea and this condition called Pickwickian syndrome, which has to do with hypoventilation during breathing, but no mention of the term obstructive sleep apnea. And this article was actually the seminal article, ultimately published in the New England Journal, on sleep apnea. So I got a chance to get in on the early stages of the whole sleep apnea thing. And when I came into practice in '76, started my pulmonary practice, after several years I began to give some lectures on sleep and began to get referrals, and so I built a laboratory and began to study sleep. And actually our laboratory was the first certified laboratory in the state. And so I not only practiced sleep medicine, I practiced pulmonary and critical care medicine sort of in parallel. So my whole interest in sleep spawned from that professor at Harvard that talked about the sleeping brain. At the time when I was getting into sleep and beginning to study about sleep, this was what I had to read. It was published in 1979. Today, this is sleep medicine. The field has really mushroomed. And it's been a fascinating study as far as the whole business of sleep and sleep disorders. So what I want to do this afternoon is to present several cases that are common, that will hopefully stimulate some thought and conversation, and then we'll have questions and answers. I want to leave plenty of time for that because everybody seems to have questions about sleep. Maybe somebody you know, maybe yourself, but I want to encourage that. This is a case of a young woman with insomnia. Insomnia is not a disease. Insomnia is a symptom complex. We've got onset insomnia, sleep onset insomnia, and sleep maintenance insomnia. And so when somebody presents to a clinician with a history of difficulty falling asleep or maintaining sleep, we need to decide whether or not it affects their daytime symptoms. I mean, a lot of people can have trouble falling asleep, like it may take 45 minutes to fall asleep, but they're not a bit tired, fatigued, sleepy the next day. That's not insomnia. It has to correlate with daytime symptoms of tiredness, fatigue, and sleepiness. Well, you can all read, but I just want to highlight some things. Notice that she's had trouble sleeping since high school, mostly falling asleep, so this is onset insomnia. It gets worse, particularly when there's stress. She's got a deadline, something to meet. The sleep onset is more difficulty. She's sleepy during the daytime. She has trouble concentrating and she's irritable. If you haven't developed these yourself, you know somebody that's just exactly like this, because this is probably the most common sleep disorder, onset insomnia. She knows she's obsessing about it, but sleep or the lack of it is sort of taken over her life. And that's what happens when somebody has this type of insomnia. It literally takes on a life of its own. And people build their lives around this difficulty sleeping, falling asleep. They obsess about the fact they don't get a good night's sleep. They've taken medications many times over the counter. In this particular instance, she took medications that helped her fall asleep, but she was groggy the next day, which is a typical when you take sedatives. One of the things that has to be understood when you see a patient or hear a story of insomnia, you've got to take the time. You've got to listen. You've got to understand where they're coming from. In this situation, as you review their history, you want to find out if there's anything particularly in their history that would keep them awake, like usually low back pain or shoulder pain. Gastroesophageal reflux is becoming more and more apparent. Many people will, when they lay down supine at night, they'll actually reflux, and that acid reflux can actually stimulate arousals and keep them awake. Nocturnal asthma can be a factor causing sleep problems, particularly waking during the night with breathing problems. Her fatigue and irritability appear to be more a consequence of her insomnia rather than a cause of the insomnia. And that's an important point. I would hear the history many times of, I'm fatigued. And then I would hear, I'm sleepy. Well, it's important to try to discern what's the difference. If you're actually sleepy and drift off to sleep when you'd prefer to be awake, or get drowsy when you would prefer to be awake, that's excessive sleepiness. Fatigue is muscle weakness, tired, just listless. We've all sensed that. So when you hear a history of fatigue, you need to define whether or not it's actual sleepiness or is it truly fatigue with muscle weakness. Medications are key. A lot of people with insomnia, particularly onset insomnia, are type A's, and type A's will frequently have an associated problem with ADHD, and they're taking stimulants, and they're drinking coffee, or they're taking something, and this can actually affect their ability to fall asleep. Insomnia is in a sense, a mental problem. People make the problem worse because the more they obsess about falling asleep, the more their mind's turned on, and the less chance they have of actually falling asleep in a natural, normal way. And type A's are 99% of those people that we see in the sleep clinic with onset insomnia. They try to will themselves to sleep. And the harder you try, the worse it gets. And part of the treatment is to try to teach them how to not to do that. A little more history. What's their environment like? Does their husband snore? Is he more active in bed? Does their temperature in the room too high? Usually too high is the problem. People don't usually sleep well. The temperature is elevated. People typically sleep better when the temperature is lower. They may be afraid, privacy issues and so forth. And the condition of the bed makes a difference, particularly in older people. In younger people, college students, high school students, it makes no difference whatsoever. They can sleep as well on the floor as they can on a Simmons Beauty Rest. We actually did a study several years ago where Simmons asked us to compare their mattress with another company's mattress, and we used as a control mattress that had just been destroyed. And the subject were medical students and college students, and they slept just as well on the torn up mattress as they did the two high-end $2,000 mattresses. So the younger you are, the easier it is to sleep without worrying about the mattress. As you get older, it makes a little bit more difference. It's vital when you talk to a patient that has insomnia to get some sort of pattern of how they do things over time. And we've been using a sleep-wake diary for years. And basically the sleep-wake diary tells us and the patient, and this is important for the patient, it is for the doctor, what time the patient typically goes to bed, how long does it take them to fall asleep, when do they wake up in the morning, is this a nightly thing, is it a weekday thing, is it a weekend thing? And so you get a pattern over a couple of weeks when you look at the diary as to what type of sleep pattern that person has gotten. Is it a chaotic pattern where they tend to go to bed an hour or two different every night, or is it pretty consistent? They fall asleep at a certain time. Do they drink caffeine? Even a small amount of caffeine in chocolate can affect some insomniacs. Just that little bit will be enough of a stimulation to keep them awake. What do they do as far as a vacation? When they go away from their own bed, how do they sleep? When they get away from the stress and the things that affect their sleep quality, do they sleep any better or any worse? And some of the options to treat these folks, cognitive behavior therapy and sleep hygiene are probably the most effective. And I'll talk a little bit in a second about pharmacologic therapy. But the basics of cognitive behavior regimen, and this is important, I want to emphasize this, so if you're turning off right now, wake up and pay attention. This is as important as anything I want to say. And it's important to start in this cognitive behavior pattern in the morning. They need a constant wake time. Only use the bed for sleep. In other words, don't work on your homework, your computer, whatever. Sleep and sex is about the only thing that I think is legal within insomnia for the bed. Try to avoid problem solving. When you go to bed, this is probably the most difficult thing for most people because it's quiet and things are shut down and they think, oh no, I got a presentation tomorrow, I've got to do this, I've got to do that, I've got to be there on time and so forth. And so this just starts churning in their mind. It's not necessary to eliminate daytime naps altogether. A 10 to 15 minute nap in the mid part of the day is not going to affect your ability to fall asleep at night. Now, a 45-minute to an hour and a half nap in the middle part of the day, yes. Even a 20-minute nap at 7 p.m. in the evening will affect your ability to fall asleep. And it's very typical for people to sit down and at the end of the day they're tired and they're watching TV, and they'll drift off to sleep for 20 minutes, and consequently they have more difficulty falling asleep that night than if they had not taken that evening nap. But the afternoon naps are acceptable and they're reasonable, and it doesn't affect your ability to sleep at night. The next one is as important as any, and that's don't go to the bed unless you're sleepy. Many people think, okay, it's 10:30, it's my bedtime, I need to go to sleep, and you're not at all sleepy. And you lay in the bed, and you typically start thinking about either you can't fall asleep or you've got something to do the next day, and so your mind gets turned on. And if this happens, and happens time and time again, your bed becomes more of a battleground, a place to worry, a place to have anxiety, and not a place to relax. So if you can't get to sleep within 10 to 12 minutes, get up out of the bed. Often go to another place in the house, another either bed or chair, and do something monotonous. I've told patients for years this story about one of my first patients that told me her monotonous routine, and it was to go to her laundry room and fold clothes and unfold clothes. Fold clothes and unfold clothes. And it's simply a mindless, repetitious activity that gets her mind off of not sleeping. So some people read. I mean, I have insomnia, onset insomnia. I think it began in college. I know it began in medical school, but my tendency was to stay up and read and study until 2, 3 in the morning. And so I still have the insomnia problem today. That's one of the reasons why I got interested in sleep in the early days, was to see how to deal with my insomnia. But don't go to bed until you're sleepy. And you may have to sit and read, you may have to listen to music, you may have to do something that's just mindless and repetitious, but only when you're drowsy and sleepy. And you can tell if you're reading and your eyes start drifting down and your head drops, that's your cue. If you go to bed and you pop up and you start thinking, then you need to get up and repeat that. Sometimes you may have to do that 3 or 4 times. Now that's a hard call. A lot of people think, well, I'll just lay here and I'll eventually drift off to sleep. Well, you may and you may not. Don't even take that chance. If you can't get to sleep within 10 to 12 minutes, then do that monotonous routine and don't go back until you're drowsy. Medications to treat insomnia need to be used in the right way. You need to try to consider what you're treating. Are you treating onset insomnia, or are you treating insomnia that results from waking at 3 or 4 in the morning and then having trouble going back to sleep, referred to more as sleep maintenance insomnia? So you need to consider the half-life of the medication that you're giving. If you want to give a short half-life to be able to get to sleep and you can then sleep the rest of the night, that's fine. I remember a number of years ago, they came out with a benzodiazepine medication called Halcyon. Some of you may remember it. It was a very, very effective sleep medication. It had about a 10-minute onset of action, and it had a short half-life of probably 3.5 to 4 hours. And it was very, very effective. But wow, problems began to develop, and it took us a while to figure out those problems. And what would happen, and what tended to happen, is that because of the short half-life, people around, if they took the medication at 11:30, around 4 p.m. to 5 p.m. the next day, they would have essentially a withdrawal reaction from the Halcyon. I mean, I had patients tell me that they would come in and tell me that, about 4:30 or 5, I couldn't even sit down to eat. I'm up, stressing, anxious, walking around, and it was the half-life of the Halcyon that was so short, they were actually withdrawing within the same 24 hours from the short acting of the Halcyon. The other thing that made Halcyon a bit precarious was that students would take Halcyon to sleep and go in the next morning to take the exam. And for the hour before they took the Halcyon and they studied, they couldn't remember what they studied. They were basically amnestic for that hour prior to taking that. So the fascinating thing was that they, would get most of the stuff that they'd studied earlier, but that hour before the exam, they didn't have it. They lost it, and it was the Halcyon effect. So it's important to understand what you're giving this pharmacologic agent for. The patients need to understand it. It needs a lot of explanation. And if you combine the pharmacologic therapy with this cognitive behavior therapy, it is much more effective. One of the things that happens when you give medications along with stressing the cognitive behavior problem is that people begin to depend more and more on the medication, and they don't follow that routine that I outlined a minute ago about not going to bed until you're sleepy or getting up when you can't get to sleep, those sort of things. So they just take the medication and sleep. And it can be a problem over time. Some of the newer medications that are out, particularly Zolpidem or Ambien, are very effective. They fall asleep quickly with it. You can sleep for, depending on the dose, you can sleep for 4 to 8 hours. Women that take Zolpidem need to take 5 milligrams. Adults take 10. It's a very effective medication, but it has some very, very subtle side effects. I had several patients that developed tremendous acid reflux problems that went away as soon as they stopped taking the Ambien. So there are issues related to the pharmacologic agents, and it's important to understand that if you use pharmacologic agents and you stop them, there's a withdrawal period. For instance, even Benadryl, which is mildly sedating. If you take Benadryl consistently every night to sleep and you don't take it, after 4 or 5 nights of taking it, you'll actually have delayed sleep onset for probably 45 minutes to an hour. So any type of sedative hypnotic that you take and stopping taking it, there'll be this sort of withdrawal period. And that's the biggest problem with Ambien. People would stop Ambien, and the next night they would be up for 2 hours and they would think, oh no, I can't do this anymore, so they start taking the Ambien again. And their doctors who didn't really understand this type of response would say, well, take it for 3 nights and then don't take it for the 4th night or 5th night. And the patients would go through this withdrawal, this habituation effect for 2 or 3 nights, and they'd think this is not worth it, so they start taking the Ambien again. So it can be an issue as far as taking it. Now this is a situation, let me back up. How do I back up? I want to give Liz's history, because this is a common situation, particularly as it relates to adolescents. Perfect. Wiped out in the morning. Most of my friends think I'm grumpy, have a hard time waking up. I'm completely non-functional. Anybody have any of those signs? Going around noon, I feel really good around that time. School gets out. I'm not a slacker. I study, get good grades. Mostly I study at night, sometimes till 2. Tried to go to bed early. I just can't fall asleep. I sleep like a dead person once I fall asleep. My mother's tried 4 alarms, sprays with water, etc. Nothing really wakes me up easily. So I went to my grandmother's house in Naples. Went to bed at 3 a.m. every night, woke at noon, and I felt great. This is a story of what we call delayed sleep phase. They sleep normal once they get to sleep, but their sleep complaints are because they have to get up in the morning for a job or for school. This is probably most manifest in adolescence, late adolescence, high school, early college. When you look at the normal amount of sleep that high school students should get, it's 9 hours and 15 minutes. That's the normal sleep for a high school student. How many of you know high school students that sleep 9 hours? Probably 2 or 3. The average sleep for high school students is about 7 hours. And consequently, during the day, during class, they essentially function in a twilight zone. The trends in terms of adolescent sleep is that they tend to go to bed later, night after night. They get up later in the mornings. Their sleep decreases, particularly during school or having a job. They have to be up at a certain time. And there's a lot of discrepancy between weekends and weekdays, because they can often make it up on a weekend. Particularly a high school student will, on Saturday night, if they don't go out and stay out to 2 a.m., will fall asleep about 11 or 12 o'clock, and then they'll sleep the next day till 10. And they've made up their sleep debt, and they're cool. Often they'll stay up, though, on the weekends longer than they did during the week, and Monday morning becomes very difficult. Tuesday's a little better because they get to sleep earlier. But the delayed sleep in adolescence is a big factor, particularly in children and high school students that are on the way to college and have to meet schedules. And there's a reason why there's a tendency to delay your sleep. And it's one of the early studies that was done in the field of sleep medicine. It was done in 1948 by Nathaniel Kleitman and 2 of his residents. Kleitman is actually the physician that fostered the lab at the University of Chicago. But what he did was that he took 2 of his residents and they went down into Mammoth Cave. And they stayed for a month without any cues of light, without any indication of day-night schedule and so forth. And what they discovered about themselves is that they went to sleep about 58 minutes every successive nights later. In other words, their sleep was delayed about 58 minutes from night to night to night to night. And that's where we get the idea that the circadian cycle in adult humans is more like 25 hours instead of the moon and stars 24 hours. And that's why it's easier to deal with what we refer to as east to west jet lag. Because when you're on Atlanta time and you go to San Francisco, they're about 3 to 4 hours, depending on the zones, later than we are, so you can delay your sleep better than you can actually entrain your sleep. For instance, if you're coming from San Francisco back to Atlanta, you're saying to your brain, you need to go to bed 3 to 4 hours earlier. Well, it's much more difficult to entrain sleep than it is to delay sleep, and that's primarily based on the 25-hour cycle that we've got as far as our intrinsic circadian rhythm is concerned. And that's why I think the tendency for teenagers is to delay their sleep onset. They've got a lot of environmental things going on. Many of the students that I would see got into the music issue, and they would listen to music, into the mornings, 1, 2 a.m., 3 a.m. And that was I like to listen to my music, and so they delayed their sleep. Let me talk about sleep apnea. This is a typical history of a male with sleep apnea. And I should point out that the incidence of sleep apnea, the incidence is primarily male over female. 4 to 1 males to 1 female as far as the incidence of prevalence of obstructive sleep apnea. The reason for that has not always been defined, but what we think it is that the male weight distribution is typically upper body. And that's what affects the size of the lungs, and I'll talk about that in a second. Female weight distribution is usually hips, lower leg, upper legs, and that doesn't affect the diaphragm and the chest as much as the upper body weight distribution of adult males. So this is a typical history of a patient and his wife that has obstructive apnea. And by the way, the male with sleep apnea almost never initiates a referral to a sleep center. It's always the spouse, the bed partner. And they're the ones that hear the snoring, the choking, and eventually they'll get the patient to come in. The wife is usually sitting on the edge of the chair, bright-eyed, glad she's had somebody that'll listen to her. The guy's sitting back in the chair, often with his eyes slanted, thinking, what am I doing here? I sleep pretty good. In fact, I can sleep whenever I want to. Well, they don't realize that's the problem. They sleep too much. This guy was told by his wife, and she told the doctor that he'd been snoring for years. He got a history talking to his high school roommate that he'd been snoring since college. And so he estimated that he had probably been having obstructive apnea for well over 35, maybe 40 years. It's important to correlate, and many of you that work with me in the clinic know how obsessive I am about doing what's called an Epworth sleepiness scale. And that's to assess what the patient feels like their sleepiness is all about. How sleepy are they in the daytime? Because many people can have sleep apnea that meets the diagnostic criteria of apnea. In other words, 15 apneas per hour. But they're not at all sleepy in the daytime. And they have an Epworth score of 3 or 4. And an Epworth score basically is a way we quantitate the patient's perception of their daytime sleepiness. It's not tiredness, it's not fatigue, it's how they may drift off during the sleep. And so correlating the nighttime symptoms that you hear usually from the spouse with the daytime tiredness and sleepiness is important. Notice that this guy actually drifted off to sleep at a red light, banged the car in front of him, which is fairly common. Notice that the patient is also on medications for high blood pressure. High blood pressure, acid reflux, depression are some of the most common comorbidities associated with sleep apnea. Approximately 75% of patients with sleep apnea will also have an elevated of their systemic blood pressure. Very common. They're often on 1 or 2 medications because it's affected, the blood pressure is affected by the systemic nervous system. And when people have apnea and their oxygen saturation in the bloodstream drops, the body releases norepinephrine, epinephrine as sort of a protection. It causes an arousal response, it causes an increase in blood pressure. But this happens virtually every time the patient has an apneic event. And then the next day, there's a higher circulation levels of these catecholamines, and that's what drives the pressure up. And it's also interesting to note that once the apnea is treated successfully, the blood pressure often goes down and the patient requires less blood pressure medication. Here are the major points as far as Ed's story and the typical apneic story. There's loud snoring, there's these choking sounds that I just indicated, daytime sleepiness, poorly controlled hypertension, and obesity. Obesity plays a role in apnea because it affects the size of the lungs, particularly upper body obesity, chest wall and abdomen. And when that develops and you lay down, you're supine, the abdominal contents push the diaphragm up into the chest. The chest cavity stays the same, but the lungs inside the cavity get smaller because of the diaphragm being pushed up. And when the lungs get smaller, the airways in the lungs get smaller, and the collapsible portion of the airway behind the base of tongue gets smaller. And typically when somebody's sleeping, particularly on their back, invariably people when they sleep will drop their mouth open. And the mouth doesn't fall this way, it rolls back. And so you roll your tongue back in the back of the airway, and you'll typically get the tongue dropping back, blocking the airway. And if that airway stays obstructed for 10 seconds or longer, that's what we define as apnea. And it's often associated with a desaturation of oxygen. We did an interesting study a number of years ago with the Atlanta Falcons. I got to know Jerry Ray, who was their trainer, and we talked about sleep apnea, particularly in big guys. And so he sent most of his offense and defensive linemen into the clinic to be tested, and 93% had severe sleep apnea. In other words, they stopped breathing more than 30 times an hour. Now, 2 of them decided that they wanted to use CPAP. One of them was William Andrews, and he used CPAP, and it literally changed his life. But the majority of them didn't want to use treatment, didn't want CPAP. But the point I'm trying to make is, these are big guys with big chests, and big abdomens, and that's what affected their lung size, and that's what caused the upper airway size to diminish, and that's what led to their apnea. Now here's something that I want to stress, and that is, Ed, I'm sending you to a sleep specialist. This represents a primary care physician, and here's the history. And instead of actually ordering a sleep study, which a lot of people will do, the mentality is it's much like a CT scan. Well, we'll get a sleep study and we'll see what it's all about. And that can be done, and the doctor can order the sleep study, but many times when the results come back, the primary care doctor doesn't really know what to do. Is it moderate sleep apnea? Is it severe sleep apnea? Is it apnea without daytime arousals and awakenings and so forth? And so there's a big question mark as to how to manage that patient. And a sleep doctor is in a position to do that far better than an ordering physician that has had no training and experience in sleep medicine. And I would tell people through the years that my job was not to order the sleep study. It wasn't necessarily to read the sleep study, because a technician could do that. My job was to help advise the patient on what's the best treatment. What should they do as far as treatment is concerned? And that's why referral to a sleep doctor is very important. Just briefly on the testing, we can do and do a lot of home testing. This is limited testing. You don't measure brain waves, so you can't determine whether the patient has arousals or not. But you can monitor their breathing, thermistor at the nose and mouth, chest wall motion, EKG, measure oxygen saturation with an oximeter. And we typically don't do home testing in a patient that's got comorbidities. We do in-laboratory polysomnography, which is the gold standard. And it turned out to have obstructive apnea, stopped breathing 42 times an hour. Heart rate dropped down to 40, and he actually slowed his heart rate to 40 during the apneic events. The treatment options, in Ed it was CPAP. Other patients can use an oral appliance. Generally, weight loss is recommended in every patient with sleep apnea. I have had numerous patients. One particular patient comes to mind, and that was a man that I saw who at the time weighed about 215 pounds. We studied him in the laboratory. He had sleep apnea. He was supposed to come back a week later for discussion of treatment. He didn't come back. We called. His wife said, "Oh, I'm sorry, Dr. Wellman, he just had a heart attack and he's in Piedmont, and the funny thing is he's not showing any apnea anymore. He's not gasping." And as it turns out, he lost about 15 pounds when he was in Piedmont over that 2 weeks associated with his heart attack, and that literally cleared up his sleep apnea. So weight loss does make a difference, and even a little bit of weight loss makes a difference. This slide is to briefly discuss the importance of setting up CPAP and following the patients that are on CPAP. CPAP is an acronym, and it means constant positive airway pressure. And what it is positive pressure. It's applied with either a nasal mask, nasal pillows that wedge in the nostril, or a full face mask over the nose and mouth, but it seals so that when the individual is wearing the CPAP, they will actually breathe, exhale into a higher pressure head. And what that does is that it keeps them from emptying about, depending on the pressure, anywhere from 100 to 125 cc's of air they would otherwise exhale on a normal breath. Well, that keeps their lungs expanded to 100 and 125 cc's above what they normally would. Therefore, it keeps their airways stented open, keeps their posterior airway open, and it has been a remarkable treatment as far as dealing with sleep apnea. However, many patients don't like it. They don't like the face, they get claustrophobic, et cetera, et cetera. So the other option in patients that have sleep apnea, particularly relatively thin patients that have a recessed chin. This has become incredibly important over the last several years. We tended to use CPAP on virtually every patient, but then we began to realize that some people did much better with an oral appliance. They liked it better, it was more mobile, and we found out that these people actually had recessed chins. Their jaw sets back, their tongue sets further back, and if you use an oral appliance and it's fitted properly and adjusted properly, it will pull the mandible forward, keep the airway open, and they actually have minimal snoring and minimal sleep apnea. But it should be emphasized that an oral appliance should be set up by somebody that knows what they're doing. Just a dentist that has not had experience with oral appliance therapy and is not used to adjusting it can actually get into a lot of trouble, because if you pull the jaw too far forward, it just creates problems with the temporomandibular joint. You get TMJ arthritis, etc., and it could be an issue. So it should be done in somebody that has experience and has done this as far as adjusting the oral appliance therapy. There is surgery that can be done, but it's difficult, it's painful. Probably the most common surgical approach really doesn't work very well at all, and that's referred to as a uvulectomy. The uvula is that little punching bag looking piece of tissue that hangs down from your palate, and it was thought early on that if you removed the uvula, that it would improve sleep apnea. Well, it stops the snoring to a large degree because the uvula is what flaps and makes that noise. But if you take out the uvula, you may stop the snoring, but you really don't do much for the apnea, because apnea takes place at base of tongue. So removing the uvula works maybe 10% of the time. Some people can actually, that uvula can actually swell up. I had a patient in the early days that came in. She was young, probably in her early 30s, and I examined her throat, and she didn't have a uvula. And I said, when did you have surgery for that? And she looked at me and kind of slanted back. She said, ain't nobody operate on me. And I said, well, you don't have a uvula. And she smiled and she said, I snored that sucker out. And what she described was that one morning she went to brush her teeth and she felt something in the back of her throat and she spit. And the little uvula was down in the sink. And the only thing I could figure out is that the uvula was sitting in her pharynx, and when it was vibrating, that was the fulcrum. And as it vibrated on that fulcrum over time, she probably had scar tissue and so forth with healing, and that became a friable piece of tissue. And she developed a scar across there, and all of a sudden, with a big, she popped that out. And by the way, she still has sleep apnea too. And a uvulectomy can be somewhat of a liability, because if you take enough of the palate out and the patient's not responsive and wants to use CPAP again, because the palate's not there and the uvula's not there, you don't get a seal at the base of tongue. And so with the CPAP in on and without a uvula, you get a lot of, they'll blow the pressure out through the mouth. And so there could be some liability to doing that. But a lot of ENTs still do that, promising that the patient's going to get better with their sleep apnea. Most don't, and I should point out it's a very, very painful operation. People hate it. I mean, it's just miserable. But unfortunately, I would see people that would come back in after they'd had a uvulectomy and said, I'd like to try CPAP again. And 9 times out of 10, they couldn't wear the CPAP again because we couldn't get that seal, and they were very disappointed.
Dr. Wellman, we have about 10 minutes left. Do we want to take audience questions?
Yep, sure do. Please, fire away. Bob. When they first fall asleep, the terminology for that is called hypnagogic hallucination, which means sleep onset hallucination. And because the individual goes into rapid eye movement sleep, which remember is dreaming sleep within sometimes seconds to minutes after falling asleep, they have this vivid hallucination. The interesting thing about the hallucinations in a narcoleptic is they're often fearful. They have a dream, a hallucination of somebody coming at them to do harm, or they're getting ready to step off a cliff, or they're very frightened. And the fact is that they're somewhat paralyzed too, because when you go into REM sleep, you lose all the muscle tone in the body, and you don't have any skeletal muscle activity. So you're paralyzed, and you're having this onset hallucination, and you eventually come awake enough, and it's a very frightening situation. It's what's driven many, many people with narcolepsy to seek medication, over-the-counter medication, or medication they could buy that would cause them to sleep that was illegal. One of the first cases that I ever had was somebody that was being prosecuted for taking amphetamines because of their narcolepsy, and they were taking it to try to prevent this early onset sleep. But the hypnagogic hallucination is a typical pattern for a narcoleptic, and it's scary. Almost all the dreams or hallucinations are scary. Bill.
Comment on the use of melatonin as a sleep aid.
It's a very mild sedative, 3 milligrams of melatonin. It's primarily used to adjust people's sleep cycles. So it's often used to adjust for jet lags, particularly when people are going across time zones consistently. They use melatonin. Melatonin is a very light sedative, and it's effective, but it's not a very powerful one. It can't overcome anxiety. Many people with onset insomnia become very anxious about falling asleep. And that anxiousness usually starts as soon as the sun goes down. And so they're trying to figure out ways to deal with that. And often they'll drink alcohol, which is one of the worst things they can do, because once the alcohol is metabolized, which is usually very quickly, they'll wake up a couple of hours after they've fallen asleep. It's very common to get the history of what's called drinker's hour. And every drinker, heavy drinker, will tell you that they will wake up about 2-3 hours after they've been asleep, and they're awake for an hour. And it's because alcohol has been metabolized out of their system. They get a little bit of drop in blood sugar, get a little adrenaline release, and they wake up. So melatonin is effective, but it's not effective as an anti-anxiety. But it's a mild sedative, and it does help. Yes.
How much deep sleep on average does a person need, say, in their 30s, 20s, and 30s?
About 7 hours and 35 minutes. That's about the average.
Deep sleep, the deepest level?
No, it's total sleep, 7 hours, 30 minutes. Deep sleep, that's hard to define. Normally, REM sleep is what, if somebody has been sleep deprived, which many patients with sleep apnea are, because they arouse every time they get into a deep sleep, because that's when the muscles relax more. And you give them a CPAP, they'll have what's called REM rebound. And the normal amount of REM sleep is about 15%. Well, some of these people with REM rebound will get 40% REM sleep their first couple of nights. And so that sleep is vital. That's the sleep that if you don't get, and you get a chance to sleep, you tend to recoup from and you tend to make up for. So deep sleep, I would say in an adult, would be about 15% REM sleep and maybe 8 to 10% delta sleep, which is the deep, non-dreaming, non-REM sleep. Yes?
I didn't really get what you concluded on from the story you told us about your professor.
Say it again now, louder.
Yeah, the brain deprived, the sleep deprived brain, does it let out a substance that induces sleep?
Say that again.
This sleep deprived brain, does it give out a substance that induces sleep? Okay, why I'm asking is because I've had experiences of people who, with mild massaging of their scalp, they get rid of their insomnia. They have insomnia, they have long period history of insomnia, and mild massaging of their scalp induces sleep. Recurrently, enough to feel it's not a flu. Okay, and I used to think maybe there was a release of endorphins or something, but that would rather be a stimulant. But from the story you said, like if there is a substance that is released by a brain deprived, a sleep deprived brain, okay, so which would imply that there exists a release by the body of a stimulant that stimulates sleep.
Are there any hormones that initiate sleep?
Hormones?
Uh-huh.
No. That's a good question. And that was the question that Dr. Pappenheimer was working with. It was whether or not by sleep depriving, in this situation, it was a colony of monkeys, could he induce a sleep promoting substance? And he was able to find out what that was. It was a small peptide that was produced that induced sleep, and the monkeys were allowed to sleep normally. That's never been, to my knowledge, ever developed and marketed and so forth. But I think that it's probably, we do have a substance that's produced in a sleep-deprived state that will help cause sleep if it can be transferred. It's still nebulous. That's not very well understood. We now think that there are mechanisms in the brain referred to as a reticular activating system, which when stimulated, that causes alertness. And by giving people compounds like Ambien and the benzodiazepines, that basically puts that reticular activating system asleep. And that's what helps induce sleep with the pharmacologic agent. Yes, sir.
Yes, how much does exercise affect those 3 different stages of sleep?
Good question. A lot. And it depends on the time of the day that you exercise. So a lot of people think that they need to get their exercise in the morning hours, and they'll get up an hour and a half early and they'll go to the gym and exercise. That doesn't make much difference in the nighttime sleep. It's the time of the day. If you exercise between 4 and 7 p.m. and you want to go to bed and sleep at 11, and you get some aerobic exercise in, it does induce sleep, and it induces deeper sleep. So it's very effective, but it depends on the time of day you do it. Good questions. Any more?
Some of the non-prescriptive supplements, as he was talking about, like melatonin and those kind of things, I've heard that over time they can cause liver damage. Is there any truth in that?
That depends on what you're, the agent.
Specifically melatonin, I was told that not to take it over a long period of time, so I was just wondering if there's any truth in that.
That hadn't surfaced as far as the literature that I'm aware of. But as you probably understand, there are many, many agents that are poorly controlled, and so you don't have a good idea of how much and how often people are taking it, so you can't really say that that's caused the liver damage per se. So I don't know of any science that says that that's the case. Doesn't mean it doesn't happen, but I'm not aware of any. Anything else? Okay. Yes?
Are you saying you should not read in bed?
No. Reading is probably the best thing you can do to relax yourself and to get your mind off of not falling asleep. So I think reading in bed for the purpose of relaxing, getting into a relatively non-stressful sleep attitude is probably one of the best things you can do. I prefer myself to not read in bed. I'll get up and sit in a chair and do my reading. But that's just personal preference. But sleeping, reading in bed, it's fine. And I think it's advisable. I mean, I've had, yes.
So with the reading part, so does it matter whether or not, like you're reading on your iPad and you're reading a regular book, does that make a difference?
That's a very good question too. I don't know of any science behind this, but I believe that if you read with an iPad that's bright, that it will stimulate you more than if the background goes dark and you read the white letters. That's just, I think it's more of a personal preference for me, but I can't help think, because the more light that the retina gets, the more it tells the body we need to stay awake. When the light goes down and the retina sees less light, that's when melatonin is produced. And so you get a little bit of an effect from that.
What do you do after an exciting basketball game when you see the hours tick by one after another?
Yeah. No, light makes a difference. Light makes a difference. Okay. Yes, sir.
I know there's apps that will filter out the blue light or kind of make your screen look more red on your computer or your smartphone devices. And but I guess there's no science that you're
I think
aware
it's
of.
the brightness. If it's a bright red, you're more, it's going to affect the retina more than it would a darker, say a blue or something like that. I think it's what stimulates the retina, and which is causing the melatonin to be produced. Melatonin is produced when the light goes down. You see a spike in melatonin. That's why people take melatonin. A lot of people will adjust their jet lag with the use of light therapy. You may have heard of the condition called seasonal affective disorder. Anybody know about that? That's people get depressed when the days get shorter, and they use light therapy to expand their daylight, expand their days, and that really does help with their endogenous depression in that situation. Okay.
Those are all the questions for Dr. Wellman?
Thank you, guys.